Guys, welcome back to Medical Coding with Blue. Today's episode is all about ICD-10-CM diagnosis coding sequencing hacks. If you are brand new to my channel, welcome. I am Blue, I'm a medical coder. Okay guys, so yes, I intentionally used a buzzword, sequencing hacks. So probably one of the most frequently asked questions I get on my channel is, Blue, when I'm coding, how do I know how to sequence? How do I know what goes first, what goes second, what goes third, and so on and so forth? Like if there's a lot of things that are serious, how do I know how to put them in? So with that said, we're going to discuss some hacks today. Now, the other thing is this. I am not tech savvy. Yes, I will admit it. I am not tech savvy. So in this episode, I will not be flashing up an example, on the screen or anything like that. But what I can offer you is this, an interactive type experience. So if you have your Optum ICD-10-CM Expert for Physicians book for 2023, I'm going to be using this book as I'm going through and talking through this episode. And so I will be calling out page numbers, and you can flip to those page numbers and follow along if you want to. And if you don't have the book, it's okay, because we're just going to talk through some of these hacks. And so that way it maybe will help you in your journey as far as like thinking, how do I get to this particular answer of the sequencing, okay? So that's the first parts that you got to know. The other thing is this. When you are thinking about what do I sequence first, what is the first thing that I'm supposed to code, the thing that you got to ask yourself is, what bought the bed? What is the reason that the patient came in for their visit? And what's going on with this patient? So let's just say, for instance, this patient is coming into the ER, right? And they fell down the stairs and they have a broken wrist. Now you have, and they were at home, okay? So now you have three codes that I just said. You have a broken wrist, left broken wrist, fall down the stairs, and this occurred at home. The place of occurrence was at home, okay? So this is in the ER, and this is the first time they're being seen for it. So everything is like initial with these injury codes, right? So one code for that broken wrist, one code for the fall down the stairs, and then one code for the place of occurrence. That seems pretty well straightforward, right? And that's the way that the sequencing goes, because the injury was what brought them in. So we know that's going to be in the number one spot. We also know that external cause codes are never going to be first listed. Never, never, ever. Never, never, ever, ever. They are always meant to complement the injury codes, okay? So that's something that you have to know. Whenever you see an external cause code, that's going to be like that fall down the stairs, or if they tripped and fell, or whatever the case may be, if they were overexerting themselves. Those things are always going to complement, they're always going to be in the next spots down, okay? So in this case, we had it at home. So that's going to be your place of occurrence. Now, place of occurrence and, those types of codes, they're going to be listed only one time, okay? So that's for statistical reasons. But that external cause code, that fall down the stairs, is going to follow that patient throughout their care, okay? As long as a provider documents that external cause code, which it is important for that external cause code to always be picked up. Now, that's one of those things that a lot of people debate about. There's some people that don't want to make that extra effort because sometimes providers get very upset because they don't understand. And sometimes because they have a lot of pressure to do a lot of things and see a lot of patients and things like that. But that's when, coaching comes in handy, and, talking with them and working with them and educating them and telling them the reasons why. If a patient keeps repeatedly falling down the stairs, there's an issue, right? So that's something that can be picked up, like as far as like looking at this record for this patient, if they're seeing that they have a history of falls. But how would they know that if they're not recording the external cause codes? You see why these external cause codes are important? Because when a patient is showing a pattern of certain things, okay, so what is going on? So then that's when somebody who is looking at this and really kind of paying attention to what's happening with this patient could either see something else is happening, or maybe they have to run additional tests or something else, right? To really make sure that the patient is safe where they are, okay? So that's the thing. That's why external causes are important. And a lot of people sort of dismiss that when they're in like the healing phase. They say, oh, we don't need to add that. And sometimes, providers just don't even want to add it when the patient comes in the initial time for their injuries. And that's bad. It's bad because these injuries could be caused by a car accident. They could be caused by a workman's comp claim, or it could be caused by another work-related injury. So always, always, always advocate for your providers to document those external causes, because they are important. And it takes less than 2 seconds for them to document how did they get that injury, okay? It is your job as a medical coder to select the codes. So if they start getting upset and saying, well, I don't want to have to select all these diagnosis codes. No, that's why I have a job. That's why I'm your coder, here to support you. So all you have to do is make sure that you're documenting. I can select the external cause code as your coder, because that is what I do. I look at the documentation, or we as coders look at the documentation to see that it supports all of the codes that are selected. If it doesn't, then we have to adjust the codes based on the specificity, or adding codes because there's something else there that needs to be picked up. So that's just what I'm going to say about that. It's very easy to fall down a rabbit hole in this kind of conversation, but I wanted to make that very clear. So always advocate for those external causes. And again, it's great for statistical reasons too, because many years ago, the state of Colorado was having a lot of spiral fractures, and they couldn't figure it out why, until they started collecting the data on why people were getting these spiral fractures, and they found out that it was because of skiing. When you go downhill skiing at a high velocity of speed, guess what happens when you crash into something? Bones tend to twist. So that was how they were able to come up with some safety campaigns and public awareness, so that people understood that, when you're downhill skiing, this is something that could happen. So this is how you can protect yourself and be careful. So there's a lot of reasons why external causes are important. But again, I don't want to get off on a rabbit hole. So your injury code goes first, your external cause goes second, and then your place of occurrence, if they have it listed. Okay, and in this instance, they did with the home. Okay, so you got your 3 codes. Now let's just say this patient also has hypertension, okay? Now the doctor says the patient's hypertension is stable, right? Even though they just hurt themselves. But the patient's hypertension has been stable, no other concerns at this time, continue on with their medication. So they're managing, as far as like not managing in like changing their medication, but they are considering it. They did think about it. They did consider that as part of their workup, because they have to. Anytime a patient comes in and has additional conditions, the factors go up, as far as like, okay, now it's increasing in capacity where the provider has to think, okay? So, but in this instance, I'm just going to make it very simple and straightforward. Hypertension is stable, and they can, continue on. So with that said, that hypertension was not the reason that the patient came in, right? They just fell down the stairs. So and the result of that fall was a fractured wrist. So fractured left wrist. So fractured left wrist, hypertension, then the external cause for falling down the stairs, and then the place of occurrence code. Now, why didn't the external cause go right under the fracture of the wrist? Because that external cause code is telling more of the story. Now, the doctor doesn't have to really consider that fall as far as their medical decision making. They did have to think about the hypertension, right? And they did talk about it, and they did say continue on with your medication, that kind of thing, and they did check to make sure that it was stable. So that's something where the doctor has to think about what's going on with this patient otherwise other than the fractured wrist. So that's the thing that you have to consider. That's why we put the fracture, then the hypertension, then the external cause for falling down the stairs, and then the place of occurrence was at the home. Okay? Because again, the external cause and the place of occurrence is going to tell more of the story, but it's not really affecting the patient. The diagnoses are going to affect the patient. Okay? Now, let's say that also in the documentation, the provider has that the patient has a history of the flu. No other concerns, nothing about it, just the patient has a history of the flu. Are we going to pick that up? No, because it has nothing to do with what is going on with this patient, that they fell down the stairs, that they have a fractured wrist, that they have hypertension. That history of flu is the same thing if they said a history of wisdom teeth removal. Okay? Okay, unless you're going to the dentist, but what relevance does it have here? But it's just, okay, do you have any past medical history? If the patient is asked this, then that's when they respond. And whoever's documenting, like the nurse, documenting those elements, then they're just going to document whatever the patient said. So that's something to think about. Not everything that you see in that note is going to be picked up. It needs to be considered as part of that care for that patient. It needs to have some kind of relevance to that episode of care. Okay, so just like that hypertension had relevance in that episode of care, that's why we picked up the hypertension. Okay, now let's just say that the patient is on a medication for that hypertension, right? I can't say any brand names, so I'm just going to say medication for hypertension. Now, let's just say that they're on it, okay? Well, how do we sequence that? You know, we got to pick that medication up, right? That long-term use medication. But how do we pick it up? Where do we sequence it at? So remember, what bought the bed? The broken wrist, right? Then the hypertension, okay? Now, what else did we sequence? We sequenced the external cause code, which was the fall down the stairs. But why not pick up that medication next, right? Because that medication, again, is more current with what is happening with that patient. It is more relevant to what is going on with that patient on the day-to-day. That external cause code was something that happened to the patient, but is telling more of the story. That long-term use medication for that hypertension is going to be part of the patient's daily life. So let's pick that one up next, right? So does that make sense? So we're going to go with that broken wrist, the hypertension, the long-term use, and then the external cause code for fall down the stairs, and then for the place of occurrence, which is the home. And that's how we get our 5 diagnosis codes. But again, you may ask, well, how do we know how to do that? Again, like I said, you're going to take the diagnoses that are like relevant, like the long-term uses, not long-term uses, I'm sorry. It's been a long day. The chronic conditions is what I mean. Like your chronic conditions like hypertension, if they had diabetes, hyperlipidemia, and they're having to look at all of these conditions and they're talking about them. They need to have some relevance to what is going on with this patient. Okay? And so we're not trying to sit here and make that decision. It needs to be documented. Okay? So that's the thing that you can hold safe. Okay? Is that you have to see what's there. And don't just look at the assessment and plan. A lot of people get kind of stuck in that frame of mind, like, oh, I can only look at the assessment and plan. No. In the outpatient encounters, this is just for outpatient. We're not talking about inpatient right now. Inpatient meaning like they stay in the hospital. ICD-10-PCS type stuff, facility type stuff. I'm talking about outpatient. So we're taking into consideration the whole document. So the HPI, right? And then the assessment and plan. Because what if the HPI said that the patient, has hypertension and then they're on long-term use medication, that they named the medication for the hypertension, and they just had it listed up in the HPI. And then down in the assessment and plan, the provider says, well, the patient has the broken wrist, the hypertension, and then continue on with plan of care from the PCM for the hypertension, and then going on to say these other things, right? And what if they didn't mention that they fell down the stairs and that it was at home in the assessment and plan? They just talked about the broken wrist. Well, guess what? You can still look at the HPI, the history of present illness, and you can still code from there, right? Because that's giving you more of that detailed information. It's not where you can just only look at one certain part of that note. Everything that is documented on that day for that on that note is fair game, right? So if you can get more of that detail from that HPI, like the external cause code and the place of occurrence and the long-term use of medication, that's what you need to use to help you to get all of the diagnosis codes that are applicable to that particular encounter, okay? So it is about sort of expanding your horizons, right, when you're looking at these documents. So I'm going to get into a little bit more of this. So when you look at your book, right, and a lot of times people will say, I just want to use the encoder. If you're just using the encoder, sometimes if you go down the wrong path, it's not going to give you those appropriate edits, like if there's something else that needs to be there, an additional code that needs to be picked up. So that's why I say, if you're really not sure going through the encoder, the electronic code book, right? If you're really not sure, then you need to make sure that you have your book, right? And if you look on page 639, and we look here, right, where it says H44.7, which is retained old intraocular foreign body non-magnetic, right? And it's got one of those little check marks with the fifth digit on it. But it says on the additional notes there, it says use additional code to identify non-magnetic foreign body. And then it gives you the Z code ranges for the non-magnetic foreign body. So it's telling you that in this instance that, let's just say it's in the right eye, the retained old intraocular foreign body non-magnetic right eye, which is H44.701, you would code that one first, followed by the non-magnetic foreign body, which is that Z code, okay? So if that's why they came in, then it's telling you that that's use additional code, okay? So use additional means that it's always going to go in the second or the third or the fourth or whatever space, but it's going to be a complement code to that code, okay? So it's not going to go before because it doesn't say to code first. It says use additional. So anytime it says use additional, that means that whatever number of diagnosis code that this is, for example, that H44.701, whatever position it's in, number one, and then maybe they have, let's see, what else could they have? Atrial fibrillation. Okay, and so that atrial fibrillation is the next listed diagnosis code. You would code that atrial fibrillation next, and then you would code that that Z code, use additional. Because those Z codes that are telling more of the story are going to go more towards the end, okay, when you don't have an external cause code. Any kind of like statistical thing like BMI is also going to go anchored towards the end of the codes. So you're going to list all of your diagnosis codes that are relevant to that visit, and then you're going to list anything that is supportive of those diagnosis codes, like the long-term use or the BMI, or in this case, the non-magnetic foreign body, you know. But if we take a look over in the second column on page 639, when we see code H46.3, which is toxic optic neuropathy, it says code first, and then it gives you a parentheses T51 to T65 to identify the cause. So in this case, it's saying to code the T code first, then you're going to code that H46.3 code. Okay, now this one is telling you the sequencing. So in this case, there is no you coded after you coded this. No, it's telling you that you're going to code first of these two codes, right? because there may be the patient may have come in for something else. So if they're coming in for something else and this is just an additional diagnosis code, you want to make sure that you code appropriately whatever first. But if this is like a second code, then it's saying that to code that T code first. So then you would code that whatever the main diagnosis code is, then that T code, then that H code, the H46.3. So if you're looking in your book, you'll see what I'm saying. So that's just what I mean. The sequencing notes will be throughout the book. It will tell you. And just know this. There are, and I'm talking fast because I'm about out of time. See, I always run out of time on these type of videos too when I get to explaining this stuff. In Appendix D, all the way in the back, in Appendix D, there is a list of Z codes. Now, there are some Z codes that are not statistical type codes, but they are encounter for codes. So sometimes you'll have a visit that's coming in for a pre-op, okay? They have a pre-op because they have the broken wrist, right? So that broken wrist is not going to go in the first listed spot. Why? Because they are there for a pre-op. So the pre-op code, the Z01818 code, will go first listed. And you'll see it here in Appendix D as Z codes only as principal or first listed diagnosis codes. So take the time to look through this list and get familiar with codes that are going to be Z codes in the very first position. Because sometimes there's going to be visits where it's a pre-op or it's an attention to type deal and that kind of thing. So those are going to be your first listed codes always. Doesn't matter what they, usually that's why they're coming in. So that's why they're in the first listed spot. So just make sure that you pay attention to those, okay? Because that's going to really help you. And you don't want to be one of those people that is putting the sequencing of those codes in, because that's what happens a lot of times for a lot of denials, is that it's a sequencing error, So really not paying attention to those sequencing rules throughout the book and then the guidelines in the front of the book, it can really hurt you, all right? So again, take the time to go through and look at all the notes where it says code first. If you're coding a pair of codes and it says to code first, then you code that code first for that pair of codes, all right? But then you look at the reason why the patient came in. Then that's my first hack. Look at the reason why the patient came in. That's going to be your first listed code. The second listed code is going to be anything that is just as treated in that visit or anything that is relevant to that care of that patient, all right? So that's, and again, it's got to be all based on the documentation as well. So that's the thing that you have to consider, all right? But one more message before I wrap this up. Now, sometimes the patient is coming in for, a post-op visit, right? Let's just go very easy, orthopedic aftercare, Z4789, okay? That's where they're coming in, but the doctor notices that they said, or the patient says, maybe they had surgery on their knee, right? In the Z4789, because it was just a scope, right? They just did a scope on their knee. They weren't injured or anything, they just did a scope. And then they say, well, doc, I have a problem with my shoulder, and the doctor says, okay, well, I'm going to do additional workup. And so they decide and they do all this extra workup on something that has nothing to do with this orthopedic aftercare. So the patient is saying, my shoulder's bothering me, and then the doctor's going to work up this extra workup. So what they do is, in that instance, even though the patient is there for that orthopedic aftercare, what happened? The patient is complaining about their shoulder. So that shoulder pain, let's just go with shoulder pain, is going to go in the first position, because that's what that shoulder pain is going to be connected to the E&M code. So when you have a patient who is in the global period and they have an E&M code and they also have that 99024, which says that they're in the global period, so that E&M code is going to get a modifier 24 attached to it. That E&M code is always going to be in the first listed position on the procedure codes, right? So that, let's just say it's 99214. I'm just spitballing, guys. Don't hold me to that. It's 99214 with the 24 modifier, okay? And that's going to be connected to the shoulder pain because they gave the medication and they did all this other extra stuff with him, right? For the shoulder pain. And then they say, okay, well, continue with your PT for your knee. So that's Z4789 for that orthopedic aftercare, and that's connected to that 99024. So that's when you see if they're coming in the global period and they have a separate complaint or a separate thing that is separate from their surgery, that diagnosis code is going to go first because it's going to be connected to that E&M code, which is going to be reported first because there's money on that E&M, okay, with that 24 modifier that says this is a separate evaluation and management in the global period. So, and then you're going to code for your orthopedic aftercare or joint replacement or whatever, right? And then it's going to be connected to your 99024, which is your global period CPT code. Okay, so I hope I don't run out of time for this video. But yeah, so if that was not confusing for you, I hope it wasn't. But that's just something that you have to think about when you are coding these things. Why are they there? Okay, and if there is something that's attaching to an E&M code and they're in the global period, then those diagnosis codes are going to go first, then the orthopedic aftercare or whatever, okay? Because that's going to be attached to that. They call it linking the diagnosis code and the procedure code, okay? So that's something else that you got to pay attention to. So with that said, I hope these hacks help you pay attention to the guidance throughout the book. And remember to think about why they came in, and think about if they paid attention to any of these additional conditions and if they did something else for them. And if they did, then you're going to rank them from most serious thing that they treated to, the least. All right. So that's how you can, least meaning that they didn't really do anything for it, but it did affect their plan of care. Okay. So again, it's all based on the documentation. So again, I hope this was helpful. If this video helped you, please like, subscribe, and share, and I'll see y'all next time. Bye.